Hi, everyone. Good afternoon and welcome back. Today, we're joined by Dr. Eddie Stenehjem to give our weekly COVID-19 update to the community to talk through how we've been doing since the last time we spoke. Eddie, thanks for joining us as always.
Thanks for having me back, Amanda.
Yes. So I want to go over case trends first, like we normally do. The state of Utah has a total of 342,445 cases. Today's case counts, the numbers were released, so that's based off of today, is 1,761 with a 7-day rolling positive average of 16.1. Our deaths are at a total of 1,620, and today we had no new deaths. Our hospitalizations are at 13,279 with today's rate at 444. And our vaccine count is up to 267,027 vaccines that have been given. Our numbers seem to be pretty far down than they have been in the past. What are we seeing in our hospitals? How are things going? And do you feel like we're moving in the right direction?
Yeah, I mean, we're absolutely moving in the right direction. Whatever metric you want to look at, whether it be case counts, hospitalizations, percent positivity, vaccinations, it's all moving in the correct direction. We've kind of got up and over that holiday spike, and now we're having pretty consistent decreases in cases. And, that has now led to decreases in hospitalizations. And so if you look across the state, if you look at new hospitalizations per day, at the peak of our pandemic, we were at about 100 hospitalizations per day across the state. We're now down to about 50. If you look at hospital census data, all of that is headed in the right direction. So case counts going down, then we had decreased hospitalizations. Next, we'll have decreases in ICU census. And so all of this is heading in the right direction. And I think we're probably going to start seeing here shortly decreases in deaths. And as we know, deaths are the last thing that get reported because it's kind of the end result of a long chain and a long illness. So everything looks to be moving in the right direction, which is incredibly encouraging because what that tells us is what we're doing is working. And we need to keep doing that. We can't forget that a 16% test positivity rate, about 1 in 5, is still really high. That is a really high test positivity rate. So that means there's plenty of people out in the community that have COVID or not getting tested. And so we are not down to that point where we'd like to be, under 5%, ideally under 3% testing percentage. But we're moving in the right direction. So this is really good news. All of last week on call for infectious disease, and it has a different atmosphere. People are a little bit relieved. People are know that we're headed in the right direction. People are vaccinated in the hospital, and so it's just a bit more of a environment where the healthcare workers can kind of take a deep breath in.
What do you think is contributing to that number going down? Do you feel like the vaccines could potentially be causing the numbers to go down? Are people realizing a little bit more that in order to get through this, we need to kind of take up these public health measures more? Any thoughts on that?
Yeah, I think it's a lot of things. I think what made the fall and the early winter so hard were all the holidays. We had Halloween, had a big spike, dealt with that. Then we had Thanksgiving, had a big spike, and that came down. Then we had Christmas. And so I think we've gotten through kind of that holiday gauntlet in terms of the pandemic, where there was a big emphasis on social gatherings. And so I think that is one really big thing. People are heeding the advice. And I think as more and more people got sick, the more people were directly impacted. The more people had very close relatives or friend either get sick and have a bad outcome, or have friends or relatives that died, and that made it much more real. And so I think more people started heeding that advice as well. And then on top of that, you start administering a vaccine to all healthcare workers, and now into teachers and people above age 70. That is certainly helping. And if you look at the fact that, now we have 225,000 people having at least one dose of vaccine, and we have well over 300,000 people that have been documented infected, probably twice as many that have been infected but not tested. So we're now, what that does is it decreases the susceptible population to COVID-19. We're not at herd immunity by any means, and we've talked about whether or not that could exist or not because of how long immunity lasts. But there's fewer people that could get infected, and people are heeding this advice. Masks are relatively universal everywhere. So people are doing the right thing, and I think our cases are showing it.
You bring up that people are doing the right thing, and one of the things that a lot of the news outlets have been talking about is this concept of double masking. Dr. Fauci mentioned it last week. What are your thoughts on the concept of wearing two layers of a mask, whether that's a surgical mask plus a cloth mask or a combination? Is there any evidence to support that that's a great thing that we should be doing?
So there's plenty of evidence now that there's plenty of evidence to say that masks work in terms of both preventing you as the mask wearer in terms of preventing infection, and also ensuring that the public is safer if you were infected and didn't know it in terms of spreading the virus. What masks do is they act as a physical barrier, either from virus particles coming from your mouth or nose out, or from somebody else's mouth or nose into yours. And so quite frankly, they're just acting as a physical barrier to interrupt that spread. And so the more layers you put in between that source and your mouth, the more protected you're going to get. And so, as these new variants are coming that are more infectious, that makes us stop and say, okay, how do we make masks more effective? And that's increasing that barrier in between somebody who's infected and yourself. And so one method to do that is to put more layers or a double mask to do that. I think the first priority though, and I think this is kind of where this is headed, is that up until now, it's just been wear a mask. There hasn't been any kind of discussion about, is it a quality mask? Is it a mask that actually fits on your face? Is it one that has a nose bridge and actually stays there? Or does it move when you talk? And we've all seen people wearing these masks either below their nose or on their nose, but it's falling off. And so I think the bigger kind of thing that this raises is the fact that people just need to wear quality masks. And quality masks are well fit. They don't have big gapes and big holes, under or besides your nose or on the side. That they're a well-fitting mask with multiple layers of material made up of the mask. And so I think that is really needs to be the focus. People are wearing masks, and we commend everybody for doing that and saying thank you for doing that. I think next is just making sure that the mask you wear is of good quality, is it fits well, it doesn't come off your face, and it has multiple layers. And if that means wearing a double mask, wearing a surgical mask plus something over it, I think that's a great way to go, especially as these more infectious variants are coming in. But I think really the focus should be on wear a quality mask that fits well and offers multiple levels of barrier between somebody who could be infected and yourself.
There are a couple of scenarios I can think of where wearing a double mask could be beneficial. An airport per se, or maybe a busy travel location. Are there areas where maybe it's not as necessary to wear two masks if you are going to start wearing them? Is a grocery store a place that you think people need to be more considerate about their masks?
I think about those areas that are really high risk exposure areas. And so what are areas that you would potentially see a lot of people? What are areas that you can't physically distance from other people? Those are areas where you really want to ensure that the quality of mask that you wear is excellent. And so if that's wearing a double mask or wearing, a standard surgical mask with something over it, I think it's really being cognizant of making sure you've got a very good, well-fitting, functional mask, especially in those times where you can't physically distance and there's going to be a high amount of exposure near you.
You mentioned the new variants too, and I want to talk around that. There was a report that the Brazil variant has made its way to the US, We haven't talked about that one a lot on these lives. Will you explain maybe the difference between the ones that have been found in the UK, South Africa, Brazil, and if there are any others that we know of as well?
Yeah, so the main viral variants that we're looking at, there's three of them, like you mentioned, one from the UK, the B117 strain, the one from South Africa, and then the one identified in Brazil. The B117 variant, over 200 cases in the US, two identified here in Utah. The Brazilian variant just identified in Minnesota. I can assure you that these variants are here. It's just a matter of us testing more. Utah actually does a very good job of doing viral sequencing of SARS-CoV-2. I saw Dr. Dunn mentioned about 10% of people are getting sequenced. And so I can say within Utah, we have identified this UK variant. It's not likely to be the predominant variant here or the predominant type here in Utah, but it is present. The South African variant and the Brazilian variant have a couple different mutations compared to the UK variant, which may make it less susceptible to some of these monoclonal antibodies. That said, both Pfizer and Moderna have tested the response of their vaccine in individuals, and they do make neutralizing antibodies that cover these variants. So as of right now, it appears that the vaccine is going to work against these variants if these variants were to start circulating at high levels here in the United States. Time's going to tell on that, in terms of more data, but it is reassuring to know that the vaccines, the Pfizer and the Moderna vaccines, should cover these variants per the testing that Pfizer and Moderna has done recently. They do appear to be more infectious or more contagious, but they do not appear to be higher mortality risk. There's a study in the UK suggesting maybe the UK variant has a higher mortality risk, yet to be determined. But I think it's good news that it looks like our vaccines cover this. And so this really is kind of a race of vaccination with spread of viral variants. And so the more vaccine we can get out, the more protected our communities, the better. And the more we can decrease the spread of SARS-CoV-2 within our community leads to less pressure of developing new variants here in Utah.
You mentioned the two vaccines, the Pfizer and the Moderna one. I know that the other vaccines that are in clinical trials still haven't been pushed out fully, but are those clinical trials looking at the new variants at all and whether they're going to be able to protect against them, or are they not really at that phase yet?
No, they're not at that phase yet. So the two companies that are likely coming next, Johnson & Johnson or the Janssen vaccine, finished enrollment, and we're actually expecting to hear results on their phase 3 trial. Hopefully, we had thought either this week or next, because then they'll be going to the FDA to get an EUA after that if they show at least a 50% efficacy in their trials. We should be getting Johnson & Johnson vaccine data shortly. I doubt that they're going to say anything about the variants in their initial publication. Most likely, they will have potentially sub-studies coming later in all of these trials that may be focused on these, but it all also depends on are these vaccine trials in places that have high circulation of the variants? And if they don't, they're not going to be able to say much about them. But I can guarantee you there's going to be lots of study on this as we move forward and as we vaccinate more people to really identify those people that get infected after getting the vaccine and making sure we sequence their virus to make sure that those, what we call viral escape mutants, aren't one of these variant strains. And so a lot of work will be done moving into this as we go into the spring and summer.
Is it possible for more variants to also start appearing? I've talked about this a little bit with Dr. Brandon Webb and how viruses kind of mutate as they go on. Could we see hundreds potentially of the different types of COVID-19?
Absolutely. This is what viruses do. This is the reason why, we have to get influenza vaccine every single year, is to account for this antigenic shift and drift of viruses. Viruses mutate. The more they rapidly divide, the more likely they are to generate these mutations in their genetic sequences. So absolutely, this is what viruses do. And so we can absolutely expect to see more of this. And the fortunate thing is the platforms for these vaccines, this mRNA platform, that's a platform that's easily changed to develop a booster shot in the case of the spread of variants. And so if we do have a new variant that is going to be circulating in our environment, they can easily go into the lab, change the RNA sequence, and then start getting that vaccine out and potentially be served as a booster shot. So you can almost envision this being, okay, what coronavirus is now circulating in the Southern Hemisphere? Well, let's get vaccinated for that prior to the next respiratory season, much like we do the flu. That's a possibility. Not sure if that's actually going to happen or not, but you can definitely envision a world where that would happen.
You bring up an interesting point around that with just the distribution of the vaccine and kind of what's been happening in the last month here in the US. Do you feel like if we do have to get to that stage where booster shots are necessary, do you think there's going to be a struggle to get them into the hands of the people who need them?
I mean, clearly there is a struggle to get vaccines into arms. I mean, we're seeing that all over the US of trying to ramp up manufacturing, link that to operations, and actually get those shots into arms. And so obviously our huge priority right now is to use the vaccines that we have that we know provide coverage against the wild type strain that's currently here, the UK variant, South African variant, and the Brazilian variant, get them into people as soon as we can. And, clearly I think the Utah Department of Health is, working well with this, and it's really a supply issue and then getting them into arms. And so I think our main focus here is get as many people vaccinated. The Biden administration said they contracted now for an additional 100 million doses, both from Pfizer and Moderna, with the hope to have availability of over 300 million vaccines available for the US population by the end of the summer. And so I think that's an ambitious goal to get anybody who wants a vaccine by this summer. I think that's a doable but ambitious goal. But that's our main focus now. And then we'll learn more about these variants. And we're going to be learning more and more about how long does the immunity that the vaccine provides, how long does that last?
Can you give an update too around how the state of Utah, specifically Intermountain 2, is doing with the vaccine distribution? Do we have any updates on timelines for moving to the next group outside of that 70 plus? Or are we still kind of in this bubble with that group?
Yeah, so really, the vaccination of the community is occurring through the Utah Department of Health. And so Intermountain has vaccinated all of their healthcare workers that wanted a vaccine. And now we're just finishing up giving those second doses amongst our caregivers. And so Intermountain right now, we don't have any vaccines. So all the vaccines that are occurring now in the community is being done through CVS, Walgreens, and the long-term acute care centers, and then also the local health departments. And so obviously Intermountain is ready and willing to help out with the vaccination effort when that time comes.
And are we seeing any severe side effects coming from either of the vaccines? I know that when I got mine, there was a link to the CDC's website where it basically asks you every day how you're feeling and to report those. Are we seeing anything from those reports that is concerning about either of the vaccines?
No, they came out with the setting that they said there is more anaphylaxis, so having an allergic reaction to these vaccines. That is still a very, very rare event, approximately 8 in a million doses. And so that is a known side effect that could potentially happen. It's a very rare event, but that's the reason why we watch people for 15 minutes after getting the vaccine. Other than that, we haven't had any reports of any identified severe effects in the time from vaccination to follow-up. And so, in a CDC report came out as well, just saying that so far, no concerning safety signals have been determined with these vaccines. That said, keep in mind that after the second shot, it's still pretty immunogenic. And so people definitely have some side effects, especially after that second shot, that include, body aches, chills, sore arms, sometimes low-grade fever. That's normal. That's your immune system really revving up in response to the vaccine. And so that is a normal anticipated side effect of the vaccine. We have not identified anything here locally or nationally, or even internationally for that matter, for any severe unexpected side effects.
We've gotten a few questions around whether someone can take a over-the-counter pain medication before they go to get their vaccine, if that's something that you recommend, or if it should be something someone uses after the fact if they have symptoms. Does it matter either way what you decide to do?
So no great data on that. There's some theoretical work, especially in the pediatric population, around vaccine effectiveness in taking non-steroidal anti-inflammatories, things like ibuprofen or Aleve. And so what we're recommending is don't go and take something prophylactically, meaning don't take a bunch of Tylenol or ibuprofen before the vaccine. But after the vaccine, if you're having systemic symptoms that are pretty uncomfortable, then go ahead, and we usually recommend starting with Tylenol, which reduces fever and is a pain reliever, but is not an anti-inflammatory. And so if you need to take something, go ahead and take Tylenol. If you need something more, you can go ahead and take some ibuprofen. But I would wait until after the vaccine to see if you develop any of those side effects. Keep in mind, most people don't have severe side effects. And when you look at the studies that had 30,000 people in them, most people didn't have severe or moderate side effects. And so I would just say get the vaccine, wait. If you develop symptoms that are uncomfortable, you could take Tylenol. And then if you need something more, go ahead and take ibuprofen.
Another question we just got was around what commutants expect to happen after they get the second dose. Do we still need to be cautious when we go out into the public? Are we kind of in the clear to join society again? That's an interesting way to put that. But can our lives get back to normal after we get that second dose, or do we still need to be doing things? And then do we have any more data around whether we can transmit the virus after we've gotten the vaccine?
Yeah, so getting the vaccine, even getting the second dose of the vaccine, that is not a free ticket to travel. That is not a free ticket to socialize with people outside of your immediate family. All the public health messages that we've been giving in terms of masking, social distancing, minimizing your contacts, that's all still in play. And so just because you've gotten the second dose of the vaccine doesn't mean you can change anything from a public health standpoint. We still recommend everybody that's even got the second dose of vaccine, always wear a mask, minimize your contacts, minimize your social gatherings. Because the fact of the matter is, we don't know whether or not the vaccine will prevent asymptomatic or mildly symptomatic infections. We just don't know. The study endpoints showed that what the vaccines prevented was symptomatic disease, that they had symptoms of COVID-19. That's what that showed to be preventative of. And we don't know if a vaccine prevents asymptomatic infection. And so why is that a big deal? Well, if I go out and I get infected asymptomatically and I'm not wearing a mask, I'm not minimizing my contact, I can go and I can spread that to high-risk people who haven't had the vaccine. They can get severely ill and potentially have very bad outcomes. And so, just because the vaccine is here, just because you've gotten the second dose of the vaccine does not mean that you can ignore those public health recommendations. That's still in play. And we're still at really high rates here in Utah. 16% positivity, that's still very high. And so all those things still apply even after the second dose of vaccine.
I want to talk about mask types again really quickly. We just had a question around the usage of a surgical versus N95 or just a cloth mask. Do we have any additional data around what is the best quality mask? I know you mentioned earlier we in the past hadn't really focused on that. But is there more data out now that can kind of point us in the correct direction of what works the best?
I mean, clearly an N95. So an N95 is a mask that we wear in the hospital when we are doing aerosolizing generated procedures on patients with COVID-19. An N95 mask is a very tight fitting mask. You have to have it fit to your face to ensure that it has a functional seal. And so all hospital employees that wear N95 masks actually have to go through fit testing, where you put an N95 mask, you put on this hood, and they instill some, pretty smelly gas, and you have to see if you can smell it or not. And so an N95s are really dedicated to our hospitals. They're in short supply, they're costly. It's something that you have to get fit to your face. But we know that those are the best masks to prevent any kind of aerosol or respiratory droplet, any kind of that respiratory transmission. Those are the best masks. You'll see these KN95s now on the market. Those are also good masks, but those aren't fit tested. Okay, so they are still a very good mask though, in terms of preventing respiratory transmission. And those are becoming more readily available. So those are kind of one step below the N95. And then there's the hospital grade surgical masks that, I wear in the hospital when I'm taking care of general medical patients or even taking care of COVID patients that are not on the ventilator or doing respiratory procedures too. Those hospital grade surgical masks would be the next step down. Those are meant for our healthcare providers that are seeing patients in the clinics, in the hospitals. They can be used all day, but are very, very good masks. Those are different than the standard surgical masks that you can buy at Costco and those types of things, which are essentially a one and done type masks. Those are kind of the next step down. And then you have all these other masks that have been created, right? Whether it be through Cotopaxi or through bandanas or through buffs or any number of different masks that we just don't know their quality. And that's what the majority of people wear. And so I think as you focus on improving the quality of your masks, I would say look for those that are either the disposable daily surgical masks. Those are good masks that can fit pretty well. Or look for a mask that's got multiple layers, that has a good seal on your nose, goes and covers your entire face and the sides, and that fits well. And so those are kind of the things I'd think about when I'm, kind of thinking about a good fitting mask.
And how is our supply of N95s for a healthcare system? Do we have enough for our caregivers? I know the very beginning of this pandemic, there was a shortage of PPE. Have we kind of solved that problem by now?
Yeah, so our supply right now of personal protective equipment, whether it be gowns, gloves, N95 mask, eye shields, we're in a pretty decent spot. We certainly have to be prepared for, a potential another surge. And so we're very cautious about maintaining our supply. But as of right now, we have adequate supply of N95 masks.
Something else I wanted to talk about really quickly was blood type. There have been a couple of rumors, or I don't know if they're exactly misinformation. I'm hoping you can help me with that, but that certain blood types are less likely to contract COVID-19, and certain blood types are more likely to contract COVID-19. Is there any truth to that?
Yeah, so there's been some data looking at A versus O and anything in between, but all blood types can contract COVID-19. All blood types can get severe COVID and die from COVID-19. And so, yes, there's continuing to be epidemiologic studies that are looking at blood types. I think the bigger question is if there really is a signal there, and one blood type is less likely to get COVID versus the other, why is that? What is the science behind that? And could you potentially use that to derive a therapeutic or a prevention strategy? All blood types can get infected. All blood types can get severe disease. There may be a signal there, and there's some epidemiologic studies to suggest that. But I would not say that that's definitive by any means. And the fact that there may be a signal there doesn't change anything. It doesn't change how we interact with our communities. It doesn't change recommendations on public health measures. It's not like we're going to come say, if you're A positive, you don't need to do X, Y, and Z. All blood types can get infected. It is an interesting area of science to understand if that truly is the case of one is less likely than the other? Why is that? And how could we potentially use that to develop a preventative measure or a therapeutic?
Another question we just got was around asymptomatic spread. And if you're not coughing or sneezing when you have COVID, but don't necessarily know you have COVID, how could it pass to someone if there's no, quote, droplets or respiratory droplets that are coming from you to someone else?
Yeah, we know that if you are symptomatic with COVID-19, and that typically means that you're coughing and have a higher respiratory rate, you are more transmissible than if you were asymptomatic and infected, where you're not doing those things, you're less transmissible, but you still are transmissible. And there's been plenty of studies to show that. So if you compare symptomatic COVID from an asymptomatic COVID, yes, the symptomatic COVID is going to have a higher rate of transmission than the asymptomatic, but the asymptomatic can still transmit. It can transmit through fomites, through, the mouse on my computer. If I rub my nose and I touch something and somebody else comes and touches their face. And you're still, with every breath you take and every breath you expel, you're expelling respiratory droplets, just not at the rate as you would be if you were coughing or sneezing, but you're still expelling respiratory droplets, which can transmit to other people, especially in close contact when people are not wearing masks.
I think a really good test of this is going outside on a cold day and just breathing into the air. You can see your breath kind of changes and gets cold. And that's kind of a good test of seeing what your breath can do, even on a much smaller scale, which I think is interesting.
Mm-hmm.
My last questions for you are around therapeutics. There was a report yesterday around monoclonal antibodies and an update of what Intermountain has done. I actually spoke with Dr. Brandon Webb about it last week as well, but I'd love an update on how we're doing with this therapy, if there's anything new we've learned over the last couple of months with it, and just your thoughts on the topic.
Yeah, so the monoclonal antibody, which is that designed antibody that essentially is mimicking your immune response to somebody who hasn't generated one. How we use monoclonal antibodies are in people that are outpatient. They're not inpatient, so you're ambulatory patients, you're at home, you develop COVID-19, you have symptoms of COVID-19, and you're at particularly high risk of either hospitalization or a poor outcome. In those people, especially if given early, so within 7 days of your symptom onset, and ideally even before that, so very early in the course, we can give you a monoclonal antibody, and the data suggests that decreases hospitalization from COVID-19. We haven't formally done a research assessment in terms of how effective our monoclonal antibody program has been, but looking at the data and in this high-risk group, it certainly looks like this therapy is reducing hospitalizations. And I know Dr. Webb has put some rough numbers into in the field that across the state, with approximately 900 infusions have already been done. We suspect that has reduced or saved at least 100 hospitalizations from COVID-19. And so it's really an optimistic therapeutic, but people need to know about it. People need to know, okay, if I get sick and I'm at high risk, I need to get in touch with my primary care doc to be able to get this therapy. So I think it's really promising, and Utah's doing relatively well in getting it out to the communities and really identifying those people at high risk. An interesting study came out just recently that looked at using monoclonal antibodies as a prophylaxis. And so in this study, it took people that were at high risk of getting COVID-19 because they had a positive family contact in their home. And so if you had a family exposure and you were asymptomatic, they randomized you into getting monoclonal antibody or placebo. And if you received monoclonal antibody, you were much less likely to get infected with COVID-19. And so it showed another kind of proof of concept of where you can use these therapeutics in terms of both prevention and in early treatment in outpatient settings. And so I think you're going to see much more of these monoclonal antibodies as we move forward. You can even imagine, if you have a high risk patient population that for some reason couldn't get vaccinated or couldn't respond to a vaccine, you could potentially give them a monoclonal antibody that would essentially provide them passive immunity that would last probably for 2 to 3 months. And so I think there's going to be a lot of applications for these monoclonal antibodies that we're really going to be kind of flushing out in these research trials as the results come out in the next few months.
Okay, this is my real last question. Someone wants to know, are we ever going to go back to normal? And I know normal is it can be different for different people, but the normal of not wearing masks, not worrying about this virus, is there a chance we'll ever go back to that?
I would call it our next normal. It may not be our, what we're currently used to. I mean, I think, so the answer to that question is yes, absolutely. I think that day is going to be ahead of us. In order for us to get there, we really have to watch very closely our test positivity, our statewide epidemiology, the rollout of the vaccine, these variants. And so this is going to be active work for the Utah Department of Health and our healthcare networks as well. I do anticipate that once our vaccines get out to anybody who wants them, and that gets vaccinated, and we decrease our community spread significantly, which we're on track for doing that, I do anticipate there's going to be a day, hopefully not in the super distant future, that we can take the masks off and that we can, go to concerts and go back to Red Butte and do the things that we want to do. So yeah, I do anticipate that date coming. And I think it's going to be a combination of a really focused effort right now on public health measures and on vaccination. If we can focus on our public health measures and getting the vaccine out over the next 3 months, I think that the summer is going to look very different compared to our last summer. But all the modeling suggests, especially with these variants coming in, all the modeling suggests is we have to maintain our vigilance in the next 2 to 3 months in terms of public health, masking, avoiding crowds, et cetera, and vaccine distribution. I think if we can really focus on that next 3 months, I think we'll be in a much better spot. That said, this pandemic has affected all of us, and there's going to be some things that are going to be carried over indefinitely, working from home and, all these things we've gotten used to. So I don't think our next normal is going to be the same as our previous normal. But I do think that there's going to be a time in the not so distant future, hopefully this late summer, fall, where we can take the masks off. But we're just going to have to follow the data on this and see where it takes us.
I like the term the next normal. That's good.
I can't say that I came up with it. I owe it to Ann Pendo, who you've had on your show a couple times. That's her. So I stole it from Ann. So thanks.
I like it better than new normal. I think it's more positive. So, Well, Eddie, thank you so much for joining us. I really appreciate it. And if you have any questions around getting tested for COVID-19, you can go to intermountain.com/COVID testing. There is a quick survey that you'll fill out to see if you qualify. And then from there, you'll be able to select an appointment arrival time. We also have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. It is a free service and anyone in our community can use it. That phone number is 833-442-2211. Thanks, Eddie, and we'll see you next week.
Thanks, Amanda.
Bye.